Well, we're talking about the coagulation phase now, the actual clot formation. And you're seeing here the fibrin threads being woven and trapping red blood cells. The red blood cells do not have a direct role in the clotting process. Clotting factors are involved in the clotting process. The red blood cells simply get stuck in fibrin threads. They simply are in the wrong place at the wrong time. They have no direct involvement in clotting. This coagulation phase can occur within 15 seconds of damage to the blood or blood vessel. It's going to lead to a sequence of steps with ultimately the formation of fibrin. And we're going to see fibrin stabilizing factor help basically cement, if you will, the fibrin threads in place. We're going to see platelets get stuck in the fibrin threads in addition to red blood cells. And the actual platelets getting stuck in these fibrin threads are going to be very important for initiating the negative feedback so that you don't have clotting occurring nonstop. You want it, of course, to eventually stop. Now let's focus on our clotting pathways. There are two pathways, an extrinsic pathway and an intrinsic pathway. The extrinsic pathway is going to be damage to tissue, tissue outside of the bloodstream, and when the tissue is damaged, it's going to release tissue factor. And I said it's a combination of lipoprotein and phospholipids. It's coming from the damaged cell membranes of the cells in that tissue. The intrinsic pathway is going to be triggered by damage to the blood itself, like physical harm to the platelets. In this case, a different type of lipid is going to be released by the platelets. Platelet factor 3, or as I said before, it's just known as factor 3. And this is phospholipid. Anything that the platelets might be tumbling across on, like glass or plastic tubing, can actually trigger the release of platelet factor 3. So if we stop and think about a person who's on a heart and lung bypass machine, and their blood is being sent through the tubing, do we want their blood to be in physical contact with that tubing and have the platelets activated and lead to a clot? No, we don't want the blood clotting in the tubing because then it won't flow back to the patient. We heparinize the tube so that the platelet factor 3 is not going to be activated. The extrinsic and intrinsic pathways begin roughly at the same time. The extrinsic pathway is much faster than the intrinsic, and they're going to converge at what's called the final common pathway. Let me go through each of the steps for the extrinsic pathway and intrinsic pathway, and finally finish up with the common pathway. Students often ask, well, why do we need two different pathways? It's very clear, actually. The extrinsic pathway, you will see, requires fewer clotting factors to assemble in order to make PAS, the beginning of the common pathway. PAS is known as prothrombin activator substance. So, very quick to assemble. It's the first responder, if you want to think of it that way, but it makes very little PAS. The intrinsic pathway begins with factors 12 and 11, and they are contact factors, which means they have to come in contact with collagen for that pathway to begin. Or, side note, you need release of platelet factor 3. So the intrinsic pathway may be slower because of a lot more clotting factors that need to assemble, but it's going to yield much, much more PAS. The extrinsic pathway, like I said, is very, very quick. It can begin in as little as 15 seconds. The intrinsic pathway is much slower, and it can take minutes for it to begin. Some textbooks say it can take up to 6 to 8 minutes for it to begin. So let's do the extrinsic pathway first. Let's follow the flow chart on the right hand of the screen. The right hand of the screen, you're seeing the tissue cell trauma. This is going to release tissue factor, which is a combination of lipoprotein and phospholipids. These are released from the damaged cell membranes. Once it's released, it's going to bind to calcium, a cofactor, which is now going to activate factor 7. Notice here that factor 7, when it's activated, has the little subscript next to it of A. So now we have the tissue factor, factor 7 complex, and this complex is now going to activate factor 10. When factor 10 is activated, it's going to bind with calcium, factor 3, in this case it came from tissue factor, and factor 5. So we are going to have 3, 4, 5, and 10 assemble to form PAS. This marks the beginning of the final or common pathway. The PAS, very little of it is made in the extrinsic pathway, but again, the extrinsic is fast. PAS, well, its name tells you what it's going to do. It's going to activate prothrombin, which is factor 2. Prothrombin is going to be converted to thrombin, and thrombin will hydrolyze fibrinogen into fibrin. The fibrin strands will start to synthesize, and factor 13 is going to cross-link them together to make them more stable. Now let's look at the intrinsic pathway. It's a good idea to know the steps of this pathway, and they basically are going to count downward. Now the intrinsic pathway, we have damage to the blood itself, maybe even to the inside of the blood vessel. Underlying collagen fibers will protrude. This is going to activate platelets. Von Willebrand factor is going to help anchor them to those collagen fibers. And as I said before, factor 12 is going to be first, followed by factor 11. Both factor 12 and 11 are contact factors. They don't require calcium. They simply need the physical contact of collagen fibers through the von Willebrand bridge, or some tests show through the physical contact from PAS made from the extrinsic pathway. Either way, they need these contacts to become activated. No calcium required. So factor 12 activates factor 11, another contact fiber or factor, which is going to activate factor 9. Factor 9 will then activate factor 8, and along with platelet factor 3, and this is released by activated or aggregated platelets. Platelet factor 3 is a phospholipid from the platelet membrane. So now we have a factor 9 and factor 8 complex, and this complex can now finally cause the synthesis of PAS. Again, we're going to have 10 plus 4 plus 3 plus 5 to actually get us a prothrombin activator substance, or PAS. I just wanted to share a little rhyme that I give my traditional physiology students. We need to remember that prothrombin activator substance is factor 3, 4, 5, and 10. How are you going to remember this? Well, if you add up 10 plus 5 plus 4 plus 3, you get the number 22. So I say to my students, if 10 plus 5 plus 4 and 3 equal 22, and I kind of whisper the word 20 and then yell out the number 2, 22, then 1 plus 13 equal glue. Well, what in the Sam Hill does that mean? Well, this rhyme emphasizes that 10, 5, 4, and 3, adding them together gives 22, meaning factors 10, 5, 4, and 3, when they're activated, will activate factor 2. That's why I emphasize the 2 in 22. And factor 2, of course, is prothrombin, and the prothrombin activator substance is going to turn prothrombin into thrombin. And then thrombin is going to activate fibrinogen, which is factor 1. That's the part I say down here, 1 plus 13 equals glue. So when thrombin activates fibrinogen, it's going to lead to the synthesis of fibrin threads. Factor 13, fibrin stabilizing factor, which comes from platelets, is going to help cross-link these fibrin threads. That's what I mean by the, quote, glue. They're going to be more set in place, more stable, these fibrin threads. Well, maybe you're wondering, what does fibrinogen look like? Fibrinogen normally is a protein found in the blood plasma, but it has a cap on the ends. These amino acids prevent the fibrin threads from linking together. These caps need to be cleaved off if the fibrin monomers are going to assemble end to end. The cleaved fibrin threads have a negative charge associated with them on one end and a positive charge on the other end. These opposite charges on either side of a fibrin monomer are going to help the fibrin monomers link up together to align, because opposites attract, obviously. But a charge-to-charge interaction is not very stable. So enter factor 13, fibrin stabilizing factor, from the platelets. It's an enzyme that's going to covalently link these fibrin threads together to form a more stable fibrin thread. Finally, we are at step 4. We need clot retraction. This can take many minutes to occur. We have the actin and myosin from the granules, and these myofilaments will connect with each other just like they do in muscle. Remember, the actin is pulled across the myosin, and this is going to help pull the torn edges of the blood vessel closer together and reduce the amount of bleeding at the injury site. It's going to reduce the size of the injured area, making it easier for fibroblasts to help recreate the torn collagen fibers. It's going to help smooth muscles, cells in the tunica media of the blood vessel, to replicate and divide and make new ones. And the endothelial cells are going to be better equipped to make repairs. This is all because of growth factors released by the platelets. Finally, our last step in hemostasis is the removal of the clot, or clot dissolution. Obviously, we don't want a clot to remain after the tissue is repaired. What actually removes the clot? Well, there's an enzyme called Plasminogen. Okay, it's a zymogen. Remember, it's made in an inactive form. It has to be cleaved into plasmin for it to now dissolve the clot. Plasmin is a proteolytic enzyme. It digests the fibrin threads through hydrolysis. There are several ways to activate plasminogen into plasmin. One way is, as the fibrin threads are being made, a lot of thrombin gets stuck in the fibrin threads. As the thrombin gets soaked up into these fibrin threads, it actually is going to be the beginning of our negative feedback for a couple of purposes. Thrombin, when it's tied up in these fibrin threads, will be less able to activate other platelets still arriving to the injured site. Also, thrombin, stuck in these fibrin threads, will be in close proximity to plasminogen, a plasma protein that's also being stuck and soaked up in these fibrin threads. So thrombin can also activate plasminogen into plasmin. There is another way to activate plasminogen, and that is tissue plasminogen activator. This is sometimes called the clot buster in the clinical setting, but it isn't. It is simply the activator of the clot buster. Plasmin is the true clot buster. For example, if someone is having an ischemic stroke, you have about an hour to administer tissue plasminogen activator to activate their plasminogen into plasmin. Why just an hour? Why not give it to them after 1 hour? The problem is, if you wait too long to administer TPA, the patient experiences about 2 million neurons dying per minute. So 1 hour, as they say, DTN, or door to needle time. And then after that, the physician really has to make a tough call. Will the patient be helped by TPA, or will it lead to more bleeding out than it's worth? Physicians need the patient to undergo tests to assure there isn't any current cranial hemorrhage, otherwise the TPA will make this worse. Blood work to ensure the patient has adequate platelet count is also needed. These tests take time, so the sooner the patient gets help, the sooner the tests are run, and the quicker the decision on how to best treat the patient is made. The problem with tissue plasminogen activator substance is that it's really, really expensive, and therefore alternatives were sought out. It's something like $2,000 to $2,500 an injection, something like that. It's very expensive stuff. Urokinase, which is found in the urine, and streptokinase, which is made from bacterium, can be used like or as if they were tissue plasminogen activating substance. Students often ask, how effective are they? When we're talking about streptokinase and urokinases, they can be used individually, but usually it's a cocktail of the streptokinase and the urokinase, and there have been debates for many, many years as to which drug to use on a clot. TPA, or the streptokinase urokinase. The European studies showed that streptokinase is probably better than TPA, but the American studies, and these were early in the 80s, show that TPA is better than streptokinase. The problem was that the American studies were using pharmaceutical companies that were owned by the physicians that were using the TPA. Since then, more studies have been done, and yes, we do have a recombinant TPA, or rTPA, that is cheaper. More current studies show that all of these drugs are extremely effective. Another recent test, they were using APSAC, or anisolated Plasminogen streptokinase activator complex. This is a complex of plasminogen and streptokinase that has been acylated to protect the enzyme's active site. In a study where they were comparing TPA or APSAC in patients with MIs or strokes, the results were so good for the APSAC that they stopped the test. It was like they said, we're not going to put these patients on TPA. We're just going to use the cheap alternative because it's just as good. It hasn't caught on everywhere yet. Some physicians still use a combination of the two, TPA and the anisolated plasminogen streptokinase activator complex. Both of them work really well at inhibiting the synthesis of thrombin, not just activating plasmin, a fibrinolytic. So it stops the clot from further expansion, and it actually leads to the dissolution of the clot that is still already there. Alright, now we're moving on to manipulating hemostasis. If we say someone's clotting times increase, that means they're taking longer to form the clot. Let's start with heparin. Heparin is released by mast cells and the basophils. These are both cells found within your body, of course. The basophils would be found in the bloodstream, and mast cells are found mostly in connective tissue. So think of the mast cells as outside the blood, and they're responsible for producing a lot of heparin. Heparin is oftentimes thought of as an anticoagulant. Well, really, it's not. It is actually supercharging the true anticoagulant, antithrombin 3. And it binds to antithrombin 3 and then turns it into a more powerful thrombin inhibitor. So a person who is on heparin is going to have longer clotting times. We can inject this into a patient. We can heparinize glass tubing. It works instantly. It binds to antithrombin 3 that's already in the bloodstream and in the plasma, and will effectively stop clotting. We can give heparin to a patient that has already demonstrated a tendency to clot. It's given to prevent future clotting. TPA, streptokinase, those kinds of drugs are given to a patient when they have a clot already and they need help with clot dissolution. It's after that, while the patient's still in the hospital, for example, that we would put them on heparin to prevent future clotting. The heparin has a very short half-life of anywhere from 1 to 4 hours and needs to be injected through an IV repeatedly. So that means this is primarily done in a hospital setting. As a side note, we do have low molecular weight heparin, which is safer. The patient can inject this into their own arm. It doesn't require an IV. It's a little bit more stable, but I'm not going to focus on that here. What if we were talking about a patient who was on a lung and heart bypass machine and their blood was going through heparinized tubing? Well, obviously, at that point, we would not want their blood to clot. But after the surgery, we will want their clotting times to decrease, to have the patient form the clot sooner. Enter protamine, which is derived from certain types of fish sperm. It is a drug that will compete for heparin. Protamine competes heparin off from antithrombin 3, and once heparin binds to protamine, antithrombin 3 becomes less effective as an anticoagulant. Again, heparin can be injected, but heparin is also endogenous and comes from basophils and mast cells. Why is that important? Well, basophils are inside the cardiovascular system, and mast cells are outside the cardiovascular system. Mast cells are in high proportion in the lung, and it's really kind of interesting. You know that heparin helps antithrombin 3 be a more powerful anticoagulant. But there are certain parts in your body where blood flow isn't laminar. Anytime you have quick changes from elastic arteries to muscular arteries to tiny arterioles to capillaries, there's going to be a lot of shear stress. And this causes trauma to the blood as it's going through a whole bunch of very narrow vessels. And as it's doing this, it very likely can instigate the intrinsic mechanism. So there's a risk when blood is going from big vessels into little vessels because you squeeze the blood into smaller vessels. And the platelets start bumping into each other, and then the platelets release platelet factor, and now you've got the intrinsic pathway beginning. Then you get blood clots in your lungs. And of course, that's the last place you would want blood clots. Those blood clots that are forming in the vessels, coming to the alveoli, and that means the blood cannot pick up the oxygen. So what's the purpose of the mast cells? They're actually dumping heparin into the blood vessel, in those smaller blood vessels. And the reason for dumping the heparin there is to prevent the coagulation of blood as it goes through the lungs. And if we didn't have this natural mechanism, a lot of us would be throwing blood clots. We would have pulmonary thrombi and emboli. Now, where else could this happen? In the kidney as well. There are a lot of changes from larger vessels to smaller blood vessels, and again, that would be a bad place to throw a clot. Okay, well, how else can we manipulate hemostasis? Well, in test tubes, we can add different types of calcium binders or calcium chelators. And there are several that we can use, and they do different things on calcium. Oxalate, when it binds to calcium, it forms a white precipitate, and this cannot be infused back into the patient. It is toxic. Citrate can deionize calcium, and this can be infused back into the patient. And just recently, I had a student ask me, Kara, when would we be doing this? Because to the student, it seems silly that we would take out a certain amount of blood that would fill maybe a test tube and do random blood tests on it and then inject that back into the person. So I explained to the student many times when people go back into the hospital, maybe for elective surgery, oftentimes they'll go weeks in advance and bank their own blood for the surgery. And so that would be a case where we could use citrate to deionize the calcium, making it an ineffective cofactor. And then we could transfuse the patient's blood back into them when it's time for their surgery. There are other calcium chelators like EDTA and EGTA that can also render calcium inactive. And remember, calcium is factor 4 and is required by many of the clotting factors as a cofactor. Now let's talk about some platelet facts and platelet inhibitors. I told you that thromboxane A2 is a prostaglandin made from arachidonic acid inside the platelet, and the enzyme that we find there is the COX-1 enzyme. Taking baby aspirin as a prophylaxis means reducing temporary ischemia, say temporary reduced blood flow to the heart. A patient who might have some coronary blockage due to atherosclerosis might take a baby aspirin as a way to prevent any temporary ischemia or reduction in blood flow, because basically of the tendency of those platelets to start getting sticky, and then they come into contact with the plaque. The problem is that the aspirin is an irreversible COX inhibitor, so it's going to block the formation of thromboxane, and the trade-off for that is the person is probably going to have longer clotting times. They're going to take longer to form a clot. Aspirin is called an antiplatelet because of where it works. Now, if you were to require surgery and you're on baby aspirin, you're going to have to stop taking that baby aspirin about a week to 10 days before your surgery. And the reason is you have to allow for turnover, for synthesis of new platelets whose COX enzymes have not been inactivated. In other words, you have to wait for new platelets to be made by the megakaryocyte and then enter the circulation and be present in high enough quantities where they can participate in the clotting mechanism. Now let's spend a little bit of time on COX-1 and COX-2 because this is a good story. As I said before, COX-1 is constitutively expressed. That means wherever you are in the body that is making prostaglandins from arachidonic acid, those places are typically using COX-1. For example, the hypothalamic cells, they used COX-1 to make PGE2, and that alters temperature set point. The gastric mucosa uses COX-1 to cleave arachidonic acid into PGE2 and prostacyclin, shown here as PGI2. And the purpose of those prostaglandins in the stomach is, of course, to make mucus to protect the gastric mucosa from all the acid content. In platelets, COX-1 is used to make thromboxane A1, which we know, when it reacts with ADP, helps aggregate the platelets. How does aspirin work? Aspirin is going to react with an amino acid in the binding spot of COX-1, and it binds to this amino acid irreversibly, and basically will render it inactive. Taking aspirin at very, very high levels, unfortunately, will target not only the COX enzyme in the platelets, but also targets the COX enzyme in the gastric mucosa. So now you're blocking the production of protective prostaglandins, and this means that with high levels of aspirin use, the person can develop ulcers. So, who would be taking high amounts of aspirin? Answer: people with inflammatory diseases, maybe rheumatoid arthritis or lupus, or maybe someone just with really bad osteoarthritis, the wear and tear type of arthritis? Well, these people are taking larger amounts of aspirin, maybe 800 milligrams plus. And this is now going to have ill effects on their gastric mucosa, and they could present with ulcers. Enter COX-2. The reason why these people are taking aspirin or Advil or any sort of NSAID is to stop, to abate the inflammatory response. In the inflammatory response, a different COX enzyme is used. It's inducible. So the macrophages and other white blood cells, they release cytokines, and this stimulates the cells, the endothelial cells that line blood vessels, to make COX-2. Those endothelial cells are going to turn on their COX-2 gene. This is the inducible version. And now these cells are going to produce high amounts of prostacyclin, or PGI2. And this is going to promote more blood flow to the area so that more white blood cells can migrate to the injured site, and this leads to edema. This is part of the reason why inflammation has the classic signs of redness from more blood flow and heat. We say rubor for redness, heat is calor, tuber is for swelling, and duller is for pain. It would be nice for someone who has these inflammatory problems to target specifically COX-2 and leave COX-1 alone so that their gastric mucosa is still intact. And that was, in fact, the case for a lot of pharmaceutical companies. They realized that they could actually make COX-2 specific inhibitors. What was unique about COX-2 that allowed the pharmaceutical companies to make specific inhibitors in the first place? Well, if you look in the top left picture up here, I'm showing you in cartoon fashion COX-1 and COX-2, and you'll notice that the COX-1 enzyme has a much more narrow binding site than COX-2. So the logic was very simple. For targeting COX-2, synthesize drugs that are much bigger. They won't be able to bind into the narrow binding site of COX-1, and therefore they will be specific for the COX-2. The problem with them was that they tipped the scales the other way. I'm sure you can recognize that thromboxane A2 is a procoagulant, and prostacyclin, or PGI2, is an anticoagulant. It promotes more blood flow. Well, by targeting the prostaglandin I2 during the inflammatory process, these COX-2 inhibitors were also inhibiting the prostaglandin I2 that was made normally by the endothelial cells. As a result, with prostaglandin I2 no longer in the mix, the platelets were more likely to come into contact with the blood vessel, and the people were having a greater tendency to clot. Now there was a trade-off for one problem for another. Although their inflammatory responses were kept in check, these patients were clotting way too excessively. Now, some of these COX-2 inhibitors that were so good, like Vioxx, that had very, very high activity rate, it was really causing clotting problems in a significant amount of people, and those drugs were recalled.